So, welcome everyone to this Requesting Changes to MedDRA session. My name's Jane Knight and I'm a clinical associate with the MedDRA MSSO. There I am on camera. I'll give you a wave. And I'm also joined today by my colleague, Dr. Samina Qureshi, who's one of our international medical officers.
Hello everyone, welcome.
Thank you, Samina. And we're also joined by another of our colleagues, Hannah Eaton, who's helping us with the logistics. And so together, the three of us will take you through this session over the next hour and a half. So with that, if you don't mind, I'm going to switch my camera off because I can find it distracting. So there we are. So the first slide just explains that MedDRA came about in the mid-1990s. It was an ICH initiative. And at the time, the MedDRA Maintenance and Support Services Organisation, or MSSO, that we all work for, were put in place to maintain and distribute MedDRA. The activities of the MSSO are overseen by a management committee, which has representatives from across the ICH regions, both the industry and the regulatory authorities. Some of the members are on your screen on this slide. The next slide is a copyright, which explains that like MedDRA, the material you're going to see today is owned by ICH, as is MedDRA. And if you use any of the material or the content, you must acknowledge ICH as owners. And if you change it, you must indicate how you've changed that material. The last bullet point relating to third-party materials isn't relevant to what we're going to show you today. So getting on to our session today, we're going to firstly explain how you do go about requesting a change to MedDRA, and I shall outline the internal MSSO process that goes on behind the scenes after you've submitted that change. Together, we're going to highlight how proposals are considered once our international medical officers get those suggestions in front of them and how their discussion goes. And we'll be telling you what are the elements that make a good submission, good being one that's highly likely to be accepted and implemented in the next release. And then we're going to discuss some actual examples that we've taken from the recent change requests. So I mentioned there were going to be some quiz questions. This is the poll everywhere information. There are two ways of doing it. The quickest and easiest way is to scan the QR code with your mobile phone, and that will give you a link that you can click and join directly. If you don't have that option, you can join either with your mobile phone or with an internet browser, and in the URL field, you type in pollev.com. Just that, nothing else, pollev.com. You will then see the screen shown here on the right, and as a username, you enter my name, Jane Knight 855. Jane Knight 855. That will then link you to the presentation, and you can click join. It's completely anonymous, so there's no risk of what you say in the quizzes being recorded or judged in any way. It's purely anonymous, just a bit of fun to make the session interactive and to help your learning. So if you forget them, you can let me know and I can bring up the QR code again, and Hannah's put the details in the chat for us. So if you have a look, the details are there in the chat ready. So the first one is, where are you joining us from today? Where in the world? At this time of day, I'd expect a number of you from North America. I'm based in the UK. I'm in London at the moment. I see North America, Germany. Anywhere else? India? Welcome, wherever you are in the world. Ooh, what is that? So, welcome. So getting on to change requests, just as some background for you, as you probably know, MedDRA is updated twice each year and it's released on the 1st of March and the 1st of September. The new releases include changes which users have requested, and these are requested known as change requests, and it's part of your subscription without any additional fees. The change requests can be for new term additions, or it can be for modifications to existing terms, like moving a preferred term to a different system organ class, for example, or changing the primary system organ class of a particular preferred term. And all of these submissions are made online via a tool called WebCR, and I'll show you that shortly. This is where you can access WebCR. You see this is the home page. So if you go to our website and you click how to use, I've highlighted that in green from the web, there's a section for change requests. This is the home page and it explains the diagram with the process here. And that's the link at the bottom right-hand side for the WebCR tool. And there are the freeze dates here, as we'll see on the next page with a bit more detail. Very important that you get your change in time for the next release. So on this page, I'll just talk a bit about the process. So what happens is that your change request is sent in, you submit it online, there's electronic checks which acknowledges to you that it's been received, and then it comes to our team of international medical officers. One of them does an initial review of the request, and that's something we call triage, and they suggest whether it should be accepted and if it is a new term, where the placement of that term should be. The change request is then given to our whole team of international medical officers who review it and make their comments. They're blinded to each other's feedback at this stage until they have a consensus discussion through telephone or video conference, and they then discuss and agree what should be the final action, should the change request be accepted, and what should the placement be. They then craft a message back to the requester explaining the decision, and there is then a chance for, if it's not approved, the submitter can resubmit with new rationale. So this is the process. And once a change is accepted, it's known as a supplemental term, and it's then added to our list, which is posted weekly, of changes online. So that's the overall process. This is the WebCR tool here. You see it, and you log on to it with your MedDRA ID. So here I've used my name because as a staff member at the MSSO, I have a name, but you would have a number. You would have a MedDRA ID, which is a 5-digit number, and you'd have a password. Now, the password you need to use here, if you're making changes to the English version of MedDRA, is a specific password called a change request ID. And I've got a slide about that one shortly. So here we see I've highlighted the freeze date. Samina, did you want to tell us a bit about that freeze date?
Yes, I'd like to comment to our users to please submit well before the freeze dates, which are June 1st and December 1st, to make sure you submit all your organizational change requests well before these freeze dates in order for us not to have a backlog and therefore not to impact the quality of the submitted CR reviews.
Thanks, Samina. So I see it's the 1st of June this year. It's always the 1st of June, isn't it? So our attendees have got almost a couple of months then to get them in. So you see there's also, I've given you some references there for some resources, some quick guides and guidance on how to make change requests and how to use this tool. So our next slide is where there's details a bit more about the password. So this is something that we often hear our subscribers get confused. So you can log on with your MedDRA ID and your web-based browser password, but that will only allow you to enter changes to the translated versions of MedDRA. So if you're using any of our translated versions and you notice things you think need to change, that's how you can access. But if you want to make changes to the English version, so structural changes these would be to MedDRA, as well as translation requests, you need to use your MedDRA ID together with the specific password that's called a change request ID. If you don't know that for your organization, you can drop us a line to our help desk and we'll put you in touch with the primary contact at your organization, and they will be able to give you the details that you need to submit the changes. There's also an instructional video cast. So if you want to watch this, because in this session we're not focusing on the nuts and bolts of how to use the tool, but you can view that in this video cast available through the training section of our website. If you click on training, there's a page for instructional videos and you can review that there. And it's in Chinese, English, French, Korean and Spanish. So, and then I think Russian is on its way for that one. This is the process that I've just talked you through, so we won't go through that again. But if you've got questions about it, please do let us know. Anything you wanted to add on that, Samina, on that diagram before we leave?
Certainly, I'd just like to let the submitters know that we do have access to various medical resources and references. So although it's ideal if in their change request they do provide a link or some sort of definition or description of the term that they're requesting, fear not if you don't. We do have access at our fingertips of various medical references in which we can do our own research.
Thank you. That's good to know, Samina. Thank you very much. So we mentioned that sometimes you will approve a request or sometimes you will not approve, but there are actually 4 actions that you can take, aren't there, Samina? One is to approve as requested, which is exactly as the submitter has entered it, but there's also an option to approve it, but not exactly as it was requested. This may be that the placement is different or the wording of the term is not exactly as requested, that kind of thing. So it's added, but maybe not in the way that the submitter intended. Then it might be not approved, or we sometimes say rejected. This is when it's not accepted, and there is feedback given to the submitter and they have the option to resubmit. Or the final one is where our IMOs feel that there's need for more discussion, maybe more widely with other colleagues at the MSSO, and so the change request will be suspended, put on hold to allow more time for discussion. So the type of considerations that our international medical officers have in their mind is that they consider and balance your needs as a submitter, but also the needs of the wider community of subscribers. And as Samina mentioned, they look at medical references, they look at the medical relevance of the term, how important it is, does it fit within the MedDRA scope and the wording of it fit the MedDRA conventions. But they also need to consider MedDRA and the stability of it long term. Obviously, we have a lot of subscribers. MedDRA's been evolving now for over 20 years, and we need to keep it as stable as possible. We don't want every 6 months there to be lots and lots of changes, because that would make it difficult to use for all our subscribers. So overall, the balance is meeting the needs of the requester, but also considering the utility of these changes for all subscribers. That's especially true when the request might be very niche requests for specific therapeutic areas. So the new term requests need to be clear and ambiguous within the scope of MedDRA, and obviously not something that already exists. We do add synonyms, but sometimes our team of IMOs will point out that the concept already exists in MedDRA. We like our terms to be single medical concepts, not due to combinations, and also universally valid medical concepts. So they need to be internationally recognized, whether that's a medical concept or an abbreviation. They need to be correctly spelled, and as I already mentioned, they need to fit with the MedDRA conventions. So those are our considerations. In terms of spelling, you're probably aware we have both American English and British English at the LLT level, but the British English is the only form represented at the PT level. Capitalization also there's a convention that it's only the first word capitalized unless it's named after an individual or it's an abbreviation or acronym. And in placement, mostly talking again about abbreviations, they're mostly included at the LLT level, except for the one exception you see there of CSF white blood cells increased. Here are some guidance documents, again with their links that you can go away and read up. There's an introductory guide to MedDRA which explains these conventions and rules, and there's also a whole document given over to background information helping you to make a change request. So that's something you might want to review in conjunction with attending the training today. So now we come on to the exciting bit of our webinar. We're going to look at some actual change requests and see how these were managed. So the request we had was to add a PT for acquired laryngocele. And the rationale we were given was from the submitter was that the company had received the term acquired laryngocele for coding. They attached a reference and point out that although commonly congenital, it may also be an acquired condition, for example, in glass blowers due to continual forced expiration, producing increased pressure in the larynx, which leads to dilatation of the laryngeal ventricle, and asking us to add that. So as you see there, our IMOs are completely blinded. They don't know who's made this request. It's all anonymized, as we still don't know now which company it was that submitted it. So let's have a look at that. What do you think, if you were on our team now, this is your chance to be an IMO for an hour, what would you do with this change request? Would you approve it as requested, not approve it, or suspend it? What do you think? Acquired laryngocele. Oh, well, hopefully there's more than one of you who's voted in this one, but it seems like however many of you have, oh, there we go, we've got a few more of you. I was going to say you've got consensus immediately. I'm not sure Samina and the team get consensus as easily as that, Samina, but here we are. We do have a slight difference of opinion. Some of you would approve as requested, but at least one of you there would approve not as requested. Now, it'd be interesting to hear if we're able to discuss live why you think it would differ, but let's have a look what the answer was. Well, it was approved as requested. Well done for those of you, the majority of you there. Samina, would you like to tell us a bit more about it?
Certainly. So this change request came in very nicely written with a good justification. And they astutely point out, because when they looked at the existing term that they had regarding laryngocele, they saw that we do have an existing PT laryngocele since version, I'd say 2.1, so ever since the beginning of MedDRA. They were astute enough to look at the hierarchy of the SOC assignment and notice that the SOC assignment was congenital. So therefore, in their scenario, they point out that there are other laryngoceles that can occur not just by birth, but they can be acquired. And here they gave us an example of such an occupation which may lead to an acquired, and therefore they had a good justification. This concept was missing because we only have right now a term for the congenital form. Therefore, it was approved as requested, and we did add it as a PT. Now, here I would also like to mention that we have another term following basically the same logic. We had a term asplenia, which exists in MedDRA since version 4.1. It is also unqualified. It was also linked to the SOC congenital. Therefore, we had a form of asplenia in which someone is born congenitally, not having a spleen. But another change request came in, and they also pointed out this condition can be acquired. For example, after a car accident, you have to, there's trauma and rupture of the spleen, you have to have a splenectomy. Therefore, that person will have an acquired asplenia. So in following the same logic, we do add, and we did add in version 20.1, so not too long ago, the PT acquired asplenia, following the same logic as this submitted term. So well done for the submitter.
Thank you, Sabina. That's interesting. Thank you. And I've just had a look, and there's no questions on that one so far. So we'll move on to our next one. That's our next example. Oh, there we are. Although more commonly, just to highlight that bit, although more commonly congenital can be acquired, as you pointed out. So this just summarizes there what you've explained, Samina, the term placement, that we can see now we have the congenital version, which is just listed as laryngocele because that's the most common, but there has the primary system class of congenital. On the left-hand side, you see the screenshot, but on the right-hand side, you see the new term that's supplemental because it's waiting for release. And we see there, as you mentioned, it's in respiratory, thoracic and mediastinal disorder. So just to summarize there. The next one was a PT that was requested, and what was requested was tattoo reaction. And the submitter told us that a delayed hypersensitivity tattoo reaction has been reported after the use of immunomodulatory therapy. The specific reaction can't be properly captured with current MedDRA terms, and so that they wanted to add it. And they've given us a reference here, medical reference. That always helps, doesn't it?
Definitely, that does help. But we have our own references as well. Sometimes we use those in addition to those provided. Sometimes the one they provide is sufficient.
That's good. Thank you. It's particularly, I suppose, particularly when people are working in a therapeutic area, it's helpful. So what would you do? Our IMOs out there on the call today, what would you recommend for this change request? Would you approve it or change it in some way or not, or suspend for more discussion? What would you do? Oh, more difference of opinion this time. Tattoo reaction. I wonder what's going through your mind. So we see this time, mostly people would approve, but not as requested. That's the most popular option, although some of our group would like to suspend it, and some of you would go ahead and approve it. But overall, they would approve not as requested. So what do you think? Samina, tell us what happened.
So although this term we did finally conclude, the team concluded it was a needed concept because, as you know, MedDRA evolves with the times, and since the inception, numerous hundreds and hundreds of terms have been added. So just to keep in line with the times and take into consideration the submitted CR, we did approve, but we felt that the term as submitted, tattoo reaction, was not it was too broad, because a tattoo reaction can be, it can produce a variety of skin reactions in different individuals depending on how their own body system reacts. It can have an acute inflammatory reaction. On the other hand, in some individuals, it can be an eczematous hypersensitivity or a granulomatous reaction. Therefore, what we did is we modified slightly the submitted term and added it slightly, changed as tattoo skin reaction. So this was a good submission, just slightly modified in the final action.
So our group was right again. It was approved, not as requested. There we are. Just to highlight there. Thank you, Samina. We're doing well today, aren't we? And the secondary SOC highlighted there as well. So our third one, this was a different type of change. This was a request to make a term non-current, and the LLT in question was cramps. So the rationale asking to make it non-current is because the submitter felt that cramps is a colloquial expression, and the coding practice shows that it's often used to describe abdominal cramps. So therefore, it's not appropriate to code vague cramps in the absence of more specific information to muscle cramps. Based on this, they wanted to make it non-current, although again, they do flag up and acknowledge that it's a resubmission because some years ago, it was already rejected. So what do we think of this one? Do we want to make the LLT cramps non-current? Is it ambiguous? Is there a risk of it being used badly? These are the current placement of it. We can see there it's uniaxial in one system organ class of musculoskeletal and connective tissue disorders. Just a bit of background for you before you vote. So what do you think? What would you vote on this one? Ooh. Ooh. I see we're split there. Interesting, isn't it? How?
I see many potential IMOs out there.
Yeah, I reckon. So, is everyone voted who wants to vote? If anyone wants the QR code, if you haven't joined in, here it is. I'll just give you one quick. If you haven't, do join us. Join in the quizzes. So, Samina, our group are saying they would not approve, and it wasn't approved. So tell us.
Very good. Yes, so the majority agreed with the same decision as our team of IMOs. So basically, we did additional research, and there were two reasons we did not approve this. Primarily based on our research, as well as our knowledge of the user community understanding. Cramps, just the LLT cramps, is generally understood to mean muscle cramps. So its current placement, as Jane showed you in the previous slide, to the musculoskeletal socket is correct, we feel, and therefore we did not approve this request to make the term non-current. The second reason is, as one of the bullet points that Jane showed us in the beginning, we have to take into consideration a nuanced approach when we accept or reject change requests. One of those factors we have to consider is how long the term has been in MedDRA and what kind of impact it will make on legacy data if we all of a sudden make a very commonly used term non-current. And since this term is frequently used and has been in MedDRA since version 2.1, it would impact legacy data greatly. And the common understanding, as we deduced from our research as well as user community, does mean muscle cramps. And therefore we decided not to make it non-current, keep its placement as is. And then we also researched and also found out that for the user community, there are existing LLT terms if their report gives additional details and tells them additional information as to the type of cramp. For example, we have LLT abdominal cramp if it's in the abdomen. We have LLT bladder cramp. We have LLT bowel cramps. And we also have LLT cramps menstrual. So depending on the whole the comprehensiveness of the report, if there's additional details, you have choices of various specific LLTs as to which type of cramp that is.
Thank you. Thank you. There's a lot behind that one, isn't there? More than you'd first imagine when you see it.
Right.
So here's another interesting one. This is a request to add an LLT of cervical vegetation. And the rationale mentions that cervical neoplasms are caused by the HPV virus infection and are transmitted through sexual contact in young women. The symptoms of cervical neoplasms are manifested and they describe them. Symptoms may include, symptoms, and then this is their rationale, but they don't actually mention in their rationale. I realise now looking, they don't mention vegetation, but they're clearly referring to cervical neoplasms. So I guess they're thinking that that's a synonym of a neoplasm or a type of neoplasm. They tend to fuse soft red papules at the beginning, gradually increasing. So what do we think about this one? Cervical vegetation, and you can read there the description of the neoplasms that they're referring to. What would you recommend for this change request? Oh, not approved was the first. Whoever's voting straight in there. Some others of you would like more time to discuss. That seems like a good idea. And some of you would approve, but not as requested. That's interesting. I wonder how you would change it. So it does seem nobody would approve completely as requested, that one.
Right. They're thinking along the lines as our IMO team was thinking. Very good.
So no, you're right. It wasn't approved at this time. So the proposal to add it was not approved. Samina, would you like to add more?
Certainly. So you were very right in saying that this is basically a description of the letter. The term is more descriptive, and it was not really found expressed as such for the two conditions that they mentioned in our medical references. So it was a vague, ambiguous, because this type of growth may be found in condylomata acuminata, otherwise known as anogenital or venereal warts, or it can also be associated, this type of growth can be associated with some forms of cervical cancer. Therefore, it's not exclusively found in one pathology or the other. Therefore, in order to avoid confusion, and as well, as I mentioned, it was not found clearly described with one pathology or another in our medical references that we checked. We found it better to reject the term.
Interesting. Thank you, Samina. Thank you. Interesting. So let's have a look at any questions. Well, I just put that next one on the screen for you. Now, I'm not seeing any questions so far. If you want to comment, feel free to comment and we'll make it interactive. This is your opportunity to have a one-to-one communication with Samina, who's normally doing her IMO job. So it's a good opportunity for you to raise your questions or comments on any of these that we're covering today. The next one was to add the LLT of scalp hematoma. A scalp hematoma typically appears as a bump on the head, The damage is to the external skin and muscle, so it will not affect the brain. A septal hematoma is usually the result of a broken nose, and a septal hematoma may cause nasal problems if a person doesn't receive treatment. Well, it looks like maybe there were two terms requested together on that one, but that should all refer to the one change request, shouldn't it? You should have one change request per entry in WebCR. So what would you do with this one? Thou wider IMO team, what would you do with this? Scalp hematoma. Let's open the polling for you. There we are. So this is a more clear decision here from our audience today that they would approve as requested. A couple of people would not approve. Maybe some people want more time. I think that would be me, Samina, always want more time to consider and think a bit more.
Right. For the complex ones, sometimes we do suspend if it's a very new medical concept or it's vague and we have disagreement between the teams. Sometimes we, like you mentioned, we have to hold a larger meeting with additional medical brains.
So overall today, the decision seems to be to approve as requested. So let's have a look what happened. Well, it was approved not as requested, but why was that? What was the change, Samina?
So this term would have been approved as requested. The only reason we did not as requested is because of the spelling. We wanted to add it as a PT, and therefore, that we add terms as British spellings, which with an extra A. As well, the reason we accepted it was a very valid concept, and it's basically a broad term that's non-qualified, just as a scalp hematoma, without any reference to which layer of the 3 layers that the hematoma is occurring in. As you know, the definition of scalp hematoma means it commonly occurs either a perinatal injury at delivery or, regardless of the delivery, in a different context as part of head trauma. Now, we do have 3 specific hematomas mentioned already as PT terms in MedDRA: caput succedaneum, subgaleal hematoma, as well as a cephalohematoma. Now, the requester here correctly noticed that if you don't know specifics in your verbatim report of which layer or which specific anatomic area this hematoma is, it's best to have a broad, unqualified term, as they mentioned, scalp hematoma. So we did add this. It's a very useful term, and as I think you will note, we do have one of the HLTs going to neonatal disorders due to birth trauma, because as I mentioned, there are subcategories of scalp hematoma that are commonly linked to perinatal injuries. And so here you see the primary SOC vascular, secondary injury in those scenarios where it's a result of trauma, and the third SOC going to pregnancy.
Thank you, Samina. Interesting. Again, the term to see the placement of it. This is taken from the right-hand side panel of the web-based browser. If you're interested in where we got our screenshot from, if you click on the term within the web-based browser, it gives you the information about the term on the right-hand side. So thank you, Samina, for that comprehensive, very interesting description there. So we've had a few examples. So I think now we can look at what we've learned, what makes a good change request. A good meaning one that's likely to be accepted. The wording, of course, is important. The wording of your new term, it needs to be clear and ambiguous, as we've mentioned, unambiguous. Make sure you pay attention to the MedDRA hierarchy, particularly if you are proposing the placement, and make sure your term fits with the MedDRA structure and is compliant with MedDRA conventions. We do ask you to provide a rationale because it really does help our team, and it means if you've come across the term, you've done some research, so share that research, share any literature articles that you may have found, or if it's a therapeutic area for you, explain to us why you need it. And overall, as Samina mentioned, we have to consider the utility. So ask yourself before you send anything in, is this change really necessary and will it benefit other subscribers? Just in the interest of keeping MedDRA stable over time.
And Janie, if I may add on your previous slide, the third bullet, compliance with MedDRA structure, the way we spell terms as well as capitalization. And if you go back another slide to our previous term, another reason we didn't approve as, one more slide back.
Oh, sorry.
We did not approve as requested is because if you see the term they submitted was scalp hematoma. The hematoma H is capitalized. And as you know in MedDRA, only the first word of the first letter of the word is capitalized. The second word letter is not capitalized. So that was another reason it was approved not as requested.
Very subtle, isn't it?
Yes.
So our group was a bit of a trick question there, wasn't it? Our group was almost right, but it was just those spelling and capitalization changes.
Right. Thank you.
Thank you. So justification. So as we've said, all change requests do require a rationale, and this rationale makes it much easier for our team. So please provide a clear description of the change and why you need it. And it does assist the IMOs in the discussion, and it can also prompt them to contact you. Sometimes one of our IMOs, although it's anonymized when they do their initial discussions, somebody might come back to you if they don't really understand what you mean by a term or why you want it. They might come back to you for further information. Anything to add there, Samina, about the justification and the importance of it?
Yes, oftentimes, the various organizations are specifically either device experts or that particular therapeutic area experts. So the justification as to why you need the term, why existing terms don't quite meet your need, it's important for us to know that. And if you don't provide it initially, this is the scenario in which we would reach out for further explanation, because you may be a better expert in that particular therapeutic area than we are. And so shedding some light helps us and make a decision.
Thank you. So here are some examples that we've received over time that we feel there is room for improvement. Please add this term. Well, that doesn't really tell us much about, and then it's less likely to be accepted. Or the primary SOC is wrong, not telling us why you think that or what you think the correct primary SOC should be. This was reported for a patient is another one that we sometimes see. Or this condition is not currently in MedDRA. I must confess to Mina, I remember years ago being working in the industry and using some of these myself, saying this term is not in MedDRA because it seemed easy. But actually, I realised now it wasn't helping the IMOs at all in understanding why I was requesting it.
Yes, any additional information, justification, or reasoning you can provide helps build your case in getting the probability of having your term accepted. So it's always a good idea to provide as much information as you can.
That's right. Here are some of the things you might include. So a definition of the condition, explaining why you need it. Please write your submission requests in English if you're asking for terms to be submitted. Although we call our IMOs international medical officers because they are scattered around the world, but we don't represent every language, and it makes it difficult for everyone to read and understand. So we do ask for them to be written in English. Don't put any information in which could identify you. So don't tell us your drug that you're working on or the name of your company, because we want it to be blind and anonymous. Medical references are useful but not essential, as is the proposed placement. You can tell us where you think it should go if you'd like to, but it's not essential. So here's an example of what we could consider as a good justification. Good in that it's a new term, it's quite a complex medical term, PCDH19 epilepsy. So it's a rare epilepsy syndrome with early onset seizures, cognitive and sensory delays, as well as behavioral problems caused by a change or mutation in the PCDH19 gene found on the X chromosome. So it's a genetic mutation here which is causing epilepsy. So this is one which it's an area that they'll be working in. They've come across it, they've done some research, and they've given us a good justification here on this one. Anything you would add to that, Samina, in terms of the justification?
No, I think it's very well written, and this is a good example of using your expertise or your therapeutic area knowledge and sharing it with us, therefore helping you boost your case or chances of having your term accepted. So this is well done.
Good, thank you. And so this was the outcome. We won't vote on this one. We can just see that it was added, but not as requested. Why was it not? It was added as a PT.
Yes, and we added it, slightly modified the term as gene-related epilepsy.
Ah, yes.
Instead of just PCDH19 epilepsy.
To make it clearer that the PCDH is the gene, I see. Yes, because that's an expanding area now, isn't it, within MedDRA, the genetic mutations. And what's interesting is when I was looking through the change requests, I realized that the same submitter had also requested PCDH19 gene mutation. So another term to capture the actual genetic mutation, as well as the resulting epilepsy, the condition that comes. So again, another good rationale, I think, pulling on the same information there. And this one was approved as requested.
Yes, and one other thing I'd like to mention here, which is a very, I'd like to congratulate the submitter, is that they did follow the recommendation that if there are related concepts with one another, to always submit those CRs as one batch. That helps the IMOs tie both concepts together and helps us in the placement of the term as well. So this was well done. They submitted both of these closely related concepts as one batch.
And so you're doing the same person is reviewing them then, aren't they, Samina, for triage?
Correct. The same person then knows the interrelationship of the various concepts in that particular batch.
And here, very successfully, are the two terms that were added. As we've just seen, the gene-related epilepsy, which being the epilepsy is there as the classifying feature, is under nervous system disorders. And then you've got the PCDH gene mutation under congenital disorders in the HLT with other gene mutations and other alterations, not elsewhere classified. So interesting to see there the two terms accepted. Another one with good justification is one where ibuprofen, it was requested as NSAID and NSAID, exacerbated respiratory disease. So non-steroidal anti-inflammatory drug, exacerbated respiratory disease. And the justification that they explain is there was a case of ibuprofen-induced respiratory disease, which raised the question of whether there should be a more specific term at the PT level. Because at the PT level, we already have aspirin-exacerbated respiratory disease, but does that, well, how then would you fit your NSAID exacerbated term in there? So good rationale here with examples of other synonyms for it. Anything else to add, Samina, about it? Do you remember the discussions on it?
Yes, so although they are correct, and we also checked in literature, the NSAID exacerbated respiratory disease is used synonymously in literature as well with aspirin exacerbated respiratory disease. But then, as we all thought about it, putting that term as an LLT under the existing PT of aspirin exacerbated respiratory disease just wasn't technically correct, because the term NSAID, it refers to in pharmaceutical classifications as a broad group of drugs that are members of a specific therapeutic drug class in which aspirin is one of the referred to as one of the NSAIDs. So we did like their idea of adding the term, but what we did is we sort of made the NSAID term as a PT and then put their requested term as an LLT underneath.
I think I've got that.
In order to represent, right, the broader category at PT level.
So there we are. So you demoted the existing PT and you put their term in as the PT. So.
Right. So their change request not only added a term, but made us think about the placement and hierarchy, and therefore resulted in that demotion.
Interesting. That sometimes happens, doesn't it? It makes you look at other terms around it. And here's the placement. We see that quite a few is added there, Tamina. In this waiting for release, these are all terms waiting for release. Look how many there are. There's the term highlighted that we've been talking about, and you've added the other synonyms as well for it.
Correct. So as I mentioned, the NSAIDs pharmaceutically is a description of a therapeutic drug class. And as you can see, aspirin, a general analgesic term, as well as the other related NSAID exacerbated respiratory, all of these are subclasses classified as LLTs under that broad category and said PT.
So quite a restructuring you did there on that one. It's interesting to see. This is in the respiratory disorders. I've just omitted a section there because I couldn't fit it on the screen, so that's why there's a gap. So let's get back to our examples for our IMOs on the call today. Examples for us to discuss. Here's one. Capillary fracture is a fracture appears in, now when I saw this one, I immediately thought capillary to me meant blood vessels. So it's interesting to see, without the rationale here, I wouldn't have known what they were talking about. Capillary fracture is a fracture that appears on a radiograph as a fine hair-like line, the segments of bone not being separated, sometimes seen in the fractures of the skull. Well, and they've given us a reference there from Dorland's medical dictionary as well as another medical dictionary. So what does our group want to do with that one? Here the vote is easier. It's a yes or no vote. What would you vote on that one? Yes or no? Let's have a look. It's a swingometer. I like to think of this one. How are we doing? Yes? The yeses are winning? Any more? Any more? Oh, the no's are pushing back. Any more here? Has everyone voted?
The majority like this term.
Oh, I don't know. Don't know, Samina. Yeah, seems like slight majority to yes. So let's close the poll. It was approved as requested. Tell us more, Samina.
So this is another example of a nicely submitted change request. They very appropriately submitted 2 references, and both of those references give the definition of the term. And in both definitions, it mentions hair-like on radiograph. So a capillary fracture is hair-like when seen on radiograph, as well as we did our own research aside from those provided by the submitter. And we found that this capillary fracture term is a synonym of hairline fractures. And also, if you look in the browser or if within the MedDRA hierarchy, under the PT stress fracture is the existing LLT hairline fracture. And since this has been proven both in the definitions as well as our research to be a synonym, we added as an additional synonym LLT under the PT stress fracture.
Oh, interesting. Thank you. See, I would never have known that without the rationale and without your explanation. Thank you. That's good. So our group did well then. The second one here, LLT, Killip Class 1. Wow, this is a classification of myocardial infarction characterized by an absence of rails over the lung fields and an absence of S3. So breath sounds. That looks like some classification system there, Killip Class 1, doesn't it?
Yes, absolutely.
So let's see what would our group do on this one. Yes or no? Yes, no. Yes is the winning again, Samina.
Yep, people like this term. They feel it was added.
Yeah, seems like overwhelming there, the yeses. So tell us what happened. It was approved, but not as requested. So our group was right. It was approved.
Correct. So the Killip classification, when we did additional research, is basically used in patients to classify risk stratification of those people with acute myocardial infarctions. Now, specifically, it's into 4 classes, and they progressively present with additional severity and increasing signs and symptoms. But Killip Class 1 is individuals with no clinical signs of heart failure, no third heart sound, or S3, also known as the ventricular gallop. So there's none of those findings, no clinical signs of heart failure. Therefore, we found it to be best placed under the PT of acute myocardial infarction, because there's no other signs and symptoms of that particular person with acute MI. Now, if you go, if you get familiarized with the other classes, the increasing classes, for example, in Killip Class 4, you have signs of cardiogenic shock, hypotension, vasoconstriction, cyanosis, signs of heart failure. So that's pretty severe. This is the one without any clinical signs and symptoms.
So you just added the one term. You didn't add all the classification. You just added the one that was asked for. But I see here that you also added it as a test, which I thought was interesting.
Correct. So we only added the Killip Class 1 since it was specifically requested for, placed it, as I mentioned, under PT acute myocardial infarction. Yet we did find that since, this is a very useful test, type of classification, we added the general PT Killip classification in our HLT, cardiac function diagnostic procedures.
So that's interesting. Thank you. I thought it was interesting to see the split there. And here we've got that on the screen so we can see the Killip Class 1 that you mentioned is primary to cardiac with vascular as the secondary. So as we'd expect, site of manifestation. And then we've got the investigations classification itself as the test.
Yes, so the test name itself, or the classification system of Killip, is under investigations, as you mentioned, and the specific finding of a Killip Class 1, as you can see, primary SOC is cardiac disorders and secondary is vascular.
Because it's a description, really, isn't it? It's a description of the person, so it goes in the in this cardiac rather than a test result as such. It's more of a classification. Interesting, thank you. Similar to the NYHA classification, are under cardiac as well. So here's a atraumatic splenic rupture that you mentioned. Oh no, this wasn't. This was the asplenia you mentioned, didn't you? This one is about spleen again. This one is atraumatic splenic rupture. They've given us quite a long rationale here. Good rationale again. We're lucky with our subscribers giving us such good rationale in our examples today. This submitter says that trauma is the most common cause of splenic rupture. However, in some cases it can happen without obvious trauma, and they call this atraumatic splenic rupture. Particularly wide groups, teenagers, young people, commonest manifestations. They tell us the symptoms, how the patient will present. The majority of cases are pathological in diseased spleen, with 3 groups being malaria, coagulopathy, and neoplasms. So they're asking for this term. What would you do? Yes or no on this one? Oh, we've got consensus. Wow, look at that, Samina. Do you agree?
Oh, 100%.
Everyone agrees it should be added, and it was added, but not quite as requested. So what's the difference here? Let me see what I highlighted. There we are. So can you tell us more?
Certainly. The reason, let's just jump to the fact that the reason it was approved not as requested is because we found that it's more commonly found in literature referred to as spontaneous splenic rupture, meaning it's not a result of trauma, but other reasons. So the wording of the new term is spontaneous splenic rupture, meaning the same thing. It's a synonym, but more commonly found in medical references. Now, the term that we currently have, splenic rupture, the user correctly surmised that because of its linkages, it refers to the traumatic splenic rupture because it goes to the SOC injury and secondary SOC blood for that unqualified term of splenic rupture. So they did have a good justification. They are very correct that we don't have a concept represented for the atraumatic or the spontaneous splenic ruptures. Therefore, we agreed and we added the term.
Yes, I was impressed with the completeness there. They point out the causes and the presentation, all of it. So it's good. Thank you. It's a good one. Thank you, Samina. As we see there, you reference that as well in your justification, for your decision. Here's the next one. The request was for a term pulmonary aspiration, and our submitter this time has given us a reference, a URL without any text. So URLs can be useful. It's nice to have some text as well, but I'll show you what they sent us. And it has the definition. So obviously they felt it stood up on its own. Pulmonary aspiration is defined as the presence of bilious secretions or particulate matter in the tracheobronchial tree, is what they're telling us about pulmonary aspiration. And that's the reference there. So what would you do with this one? Yes or no to add it? No. Oh, no. The yeses are coming back. Oh, pulmonary aspiration. It would be interesting, wouldn't it, to ask our group if we could. I wonder why. Why?
They don't like this term.
No.
Well,
close. I wonder why. I wonder if they think it's ambiguous. That's what I wondered when I first saw it. Is this ambiguous? So, Samina, tell us, what do you...
So this was actually, surprisingly a very straightforward change request. It was a concept that was needed because currently we only have PT aspiration, and under it we have several LLTs that are sort of hovering around this particular term. We have LLT aspiration into bronchus. We also have LLT aspiration into trachea. We also have LLT aspiration of gastrointestinal contents into airways. But for example, in reports where they're not very specific of exactly if it went into bronchus, if it went into trachea, you need a general term to represent what they've suggested, pulmonary aspiration. Therefore, we did add this as an additional valuable LLT under the PT of aspiration. So it was approved as requested.
It was approved. Thank you. Thank you. Here's our next one. Add a new term, difficulty closing hands. And the rationale is that while difficulty making a fist may seem like an issue that just involves the hands and arms, it turns out that grip strength problems may be a sign of a more serious issue. Well, that seems reasonable, the justification there, but not just the hands and arms, but it could be indicative of something more serious, difficulty closing hands. So our submitter is telling us the importance of having this term, why they need it. What do you think about it? Oh, split again. Slightly more people thinking no, they wouldn't be inclined to have this one. But close, very close. You'd have to have a discussion on this one, Samina, if you were with our group today.
Right. Oh, 50-50.
50-50 again. So let's have a look at what actually happened. You're split. You're really close, the audience. So it wasn't approved. The no's had it.
Right. So if I can share what our thought process was as to why we did not approve this particular term. So while it seems just off the bat something very useful to have, but if you really think about it, there are so many reasons pathologically for a loss in ability to close your hand. For example, it could be due to a sudden acute injury and there's inflammation, or it could be due to a neurological condition, or it could even be due to a overall malady such as arthritis. So because there are multiple possible etiologies, just think as IMOs or as in the MedDRA perspective, how would you link this, right? Because there's numerous pathologies, bases that this could occur. So because the term was somewhat vague, it was not accepted.
Interesting. Thank you. Thank you. I reckon that's probably what some of our group were thinking as well.
For the nose.
Liking to know, wanting to know what was actually happening. And then we're getting towards the end of our examples here. The next one, it was two terms. They were requested together in the same batch, like Samina mentioned before, but not in one change. So it wasn't in the same entry form. It was on two forms, but in the same batch. The first was sensory processing sensitivity, and the second was a highly sensitive person. And these two terms were related, the way they describe it. People who have a sensory processing sensitivity are thought to have an increased or deeper central nervous system sensitivity to physical, emotional, or social stimuli. Another term for this is a highly sensitive person, or HSP, and they've given us a reference there from psychological references of behavioural research in behavioural management. And it is a study done in the adult Spanish population. So are these terms in the scope of MedDRA, are they something that you think are internationally recognised, unambiguous, and all the other considerations? What would you do with these? Now, we've got a slightly different poll for you this time. Would you add only sensory processing sensitivity? Would you add only the highly sensitive person? Or would you add both terms? What would you do here if you had to make the decision? Slightly different poll. This one I've set up differently, so we can't see the votes. I can see how many of you have voted, but I can't see any more. Anyone else going to vote? Going up. You can't see what everyone else, so you can't be swayed by it. And that's exactly how our WebCR tool works. Once the term goes in, it goes into an internal processing system, and Samina comments on it and gives her decision, just as our other IMOs do, and they can't see one another's thoughts. So it's just as you're doing on this example. They can't be biased or led by anyone else's thoughts. Isn't that right, Samina? Until you come together.
Yes, there's a lot of anonymity in this. We don't know who's submitting, which company or organization is submitting the CR, as well as we can't see what our fellow IMOs are deciding. We make our own individual decision, and then we share our opinions. We get to see it eventually in consensus, and then we argue for or against that particular term, whether it should be added or not.
So let's have a look at what our group, oh, we don't have a vote. Yeah, we don't have a, where's our answer on that one? Well, it approved as requested. It was approved as requested. We can't see what the overwhelming vote was. I must have done something in the setup, but it was approved as requested. The proposal to add the new term sensory processing was approved. And what about the other one? Highly sensitive person was approved as well. So any discussion there, Samina, to share?
Certainly. Well, when I first saw this, it came in my queue as an IMO. I looked at this and I said, well, the first term might be some sort of definitely valid medical concept or entity. But the second term, highly sensitive person, I thought, well, that's just a very colloquial or lay expression. Perhaps at some point in our lives, we all become highly sensitive at one point or another. So it's just a descriptive lay expression. But when I did my due diligence and checked my various medical references and resources and did some research, actually these are valid standalone medical concepts. They are found in literature. The first term, therefore, was added sensory as a PT, sensory processing sensitivity, under HLT sensory abnormalities, NEC. And then the second one, highly sensitive person, was a common synonym for this, and we added it as an LLT underneath. Now, simply, we just didn't do that. As a result of this particular change request, we did some moving around of existing terms in the MedDRA hierarchy. What we did as a related change, we put the PT sensory integrative dysfunction. We demoted it under PT, an existing PT sensory processing disorder, because we found as we did our research that they are synonyms of one another. So that was one thing that was a result of this change request. Also, a term that we added not too long ago in version 20.1, sensory overload. We moved it from HLT, neurological signs and symptoms, to this HLT in which we placed this, this recently submitted PT, sensory abnormalities, NEC, for better alignment. So as Jane is highlighting, sensory overload was moved to the different, better aligned HLT, where we put the new PT. So sometimes CRs do give us a chance to look at existing closely related terms and do a little tweaking and realignment in the hierarchy.
Thank you. Let me just get rid of my drawings and then I'll show you the, here we are, Samina, do you want to, we can see them here. We've got sensory overload and the new term, sensory processing sensitivity. I haven't got all the terms that you mentioned, but there we can see the placement of those, and they're under neurological disorders not elsewhere classified, so a miscellaneous category there.
Again, emphasizing that sometimes user input helps keep related concepts aligned, and sometimes also initiates, as you saw in this case example, multiple other changes, just to keep our terms all aligned, similar concepts aligned, consistently. So again, related concepts, please submit as one batch.
That's good. Interesting one, that one. I don't know what I would have. I think I'd have been like you. I would have wanted more justification. So this last one, I think it's our last one, is algid malaria. And the rationale that came was that the company had received a report of it, and algid malaria is a complication of malaria manifesting in a state of circulatory collapse. So it seems like it's something, sequelae or a complication of malaria. Although rare, it can be rapidly fatal with a high mortality rate, believed to be caused by a release of tumour necrosis factor, impaired microcirculation and metabolic acidosis. Doesn't appear to be represented. So again, a nice rationale there. What would you do? We're back to our yes and no's now. Yes? Anyone else going to vote? Yes or no? I'm not sure what happened with my last poll. I'm sorry, I expected we would see everybody's views on that one. I don't know what happened with the polling. Can perhaps show at the end. Anyone else? No? We do have consensus, Amina. I think it's the first time this time. So
Yes.
It was approved, and tell us what about it.
So 100% of you agreed, just like our IMOs agreed to add this term. So well done. I guess through the session, everyone's getting better and better at guessing what eventually happened. So initial thoughts when you first look at this term, we thought, well, you know, algid malaria, we'll just put it as an LLT under malaria. But based on the justification and information that the submitter provided, as well as our own deeper dive into the research, we saw that yes, it is malaria, but the hallmark of this is that it's clinically very severe. It's seen as a rare complication of tropical malaria, and it's characterized by something that makes it very clinically significant in that there's hemodynamic disorders such as shock, as well as pronounced metabolic changes seen in algid malaria, as well as hypothermia. So we felt that this was clinically significant enough because of the hemodynamic complications and symptoms to put it as its own PT, or unique medical concept. So we added it as a PT. And if you, I don't know if we can access the browser or not, but I can just mention to you that both this PT, algid malaria, as well as the plain PT malaria, both go to and as Jane will show, both go to the primary SOC HLT of Plasmodia infections, but in order to emphasize the fact that there's circulatory collapse or shock in the algid malaria, we gave it the HLT of circulatory collapse and shock in order to, you know, capture that component of this unique concept, rare complication of tropical malaria.
Just bear with me, Samina, and I'll, once I get my password. Just bear with me.
Certainly.
This is because I used it for training last week, and it's the password changed and my own. Have we got, yes.
So there we go.
So remind me, Samina, where would you like to go?
We're comparing malaria and looking at algid malaria, so just to see their hierarchies.
So I've changed it to supplemental.
So algid malaria.
Let's have a look at algid. What was algid malaria? Search that one. So there it is. Algid malaria, the PT. So that's the.
So as you can see, yep, the primary SOC is of course infections, because it's going to HLT plasmodial infections, just as our regular malaria goes.
There we are.
And if you do open up the regular malaria as well, that also has the same primary SOC of plasmodial infections, plasmodia infections, but the secondary SOC of malaria is, I believe, anemias.
Yeah.
Yep, anemias, NEC, but the one that we just added, algid malaria, because of its significant clinical finding of hemodynamic shock, you will see that it has the secondary SOC going to
I've got to get
circulatory collapse and shock.
There we go. So there we are on the right-hand side. Algid malaria has a secondary. There we are, just as you've said, the secondary of collapse and shock, because that's what it's all about. That's the final feature.
It's absolutely right, Jane. It's the hallmark feature of this, and it's a complication, rare complication, but nevertheless seen as a complication of tropical malaria.
I thought this one was interesting because it's a condition with a complication, and I see so often that you say we don't add due to, something due to. So if it had been reported as shock due to malaria if there hadn't have been a term. But then when you see that there is an actual medical term for that complication, and it is a serious complication, as you say, I could see the rationale. But that's why I thought it was interesting, because the concept is a due to type of term, but it's got a concept, it is a single concept. Do you see what I mean? That's why I thought that was an interesting one.
Right. The hemodynamic shock is a result of the condition. It's a clinical hallmark of algid malaria itself, the disease state.
It's good, certainly a good one to have added for people to use because it's important. So it's good to see. So let's go back to our slides with that. Okay, so that's that one, and there it is to highlight again, dangerous form parasites like bacterial shock. And there's the term placement. So working together here, we would say, please only request the terms you need. Don't try and gap fill. Don't spend hours. I think nobody these days has the hours to spend going through MedDRA trying to find gaps that, oh, I found a term which isn't in there. And our IMOs will make the related changes. So if just request what you want, and here particularly if I'm thinking of, if you want a term and there's a test result and you want it to be increased, just ask for increased, and our IMOs will add the decreased if they feel it's necessary, as well as the test name. So that's the kind of thing. You don't have to do their job for them in that way. So if there's an abbreviated form, if you want the name of the condition, add the name of the condition and only ask for the abbreviated form of it if that's something that you would also be useful to you. Otherwise, our team will have a look at it and decide if it needs to be added. The same with the British English and American English spellings and the corresponding LLTs to PTs. I think I've mentioned to you before, Samina, again, when I was in the industry, I remember in the early days requesting the same term as both an LLT and a PT, because I thought I was helping you by reminding you that you needed to add them both. But now I realise that you're well familiar and you will do that automatically. And there's Correct. The point there, and the last one on the slide about increased, decreased. So here's a couple that we've had examples where things have not been approved and how they could have been, the request could have been improved. An example here of something that was added because they thought it wasn't in MedDRA when the concept was already there. So we would say to you, please, before you take your time sending in a change request and going through that, the effort for you of doing that, plus potential delay for you encoding, have a look and see if the concept is there with a synonym. Here we see breast cyst aspiration wasn't added because there's already an LLT of fine needle aspiration of breast. And so that the concept could have been used, and it would have been much easier for the submitter not to have to ask for a new term. And then another one here, we had a couple of requests for people asking us almost to tidy up the terms really. Carcinoid tumour in the large intestine, replacing it with carcinoid tumour of the large bowel, changing the words either for consistency or to tidy up. The same here with I should let you do this one, Samina. Echinococciasis. Is that it? Of bone.
You got it. You're better than me. You got it.
So again, asking for the change in the word order. So if you notice something like this, that we're inconsistent in our placement of terms, and there's a number of terms, remember you've always got the option to do proactive changes where you send us an email to the help desk telling us that you find there's a widespread problem around either the wording, the consistency of terms, and you'd like us to take time to do a wider review in a particular area. But just on a term-by-term basis like this, the requests are unlikely to be accepted because it is just what we might say cosmetic changes, tidying up the terms. And MedDRA's evolved over 23 years, remember, so we're not going to be perfect with the wording and consistency because we are trying to keep it stable for everyone. So that's my take on that one. Anything to add on that, Samina, from your perspective?
No, I think also, I think you mentioned before, but I'll just reemphasize. Sometimes it's when you submit a term, make sure that the utility of the term is for a broader audience and not just maybe for one particular organization. Look at the overall utility of the term for the user community.
Yes. So our overall guidance, as we've said today, is provide a clear rationale and medical references, check the existing supplemental terms as well as the existing terms to ensure that it has already been included. And you saw me do that in the browser. Let me just show you again. We see here we've got at the top left, I've got a field which is a release or supplemental view. I changed that to supplemental. I can change it back to release, and the screen will go grey again. So this is where it's here, it's on the right hand side, supplemental, and it goes pink. That will show you with the green dotted line that we just saw. It will show you the terms that have been accepted. You can also use WebCR to see if similar terms have been submitted in the past. You can refer to our introductory guide for the conventions and the placement of certain types of terms, the rules governing the structure of MedDRA, and as we've just said, please only request the terms you need, don't fill gaps. So those are our overall guidance. Now, while I just stop and pause here for questions, we'll see we've got just under 15 minutes left. So I'm going to give you a last poll asking you, do you think this webinar will help you, and how will it help you? You'll also get a survey after the webinar. This webinar typically doesn't have the large audiences that some of our other webinars have, but we certainly like to share with you what we've seen in the change request recently, and we'd like to know how we can continue to make the sessions as useful as possible for you. So please do take the opportunity when you get the survey link to tell us what you think, what you thought was good about this session or how it could be improved. And then Stamina and I can work on that for future sessions. So how will it help you? And then we'll stop and see if we've got any questions. So you can carry on voting on and we'll have a look later. Thank you. So this is what we've done today. We've explained how to request a change. I've explained the internal process, and you've had an opportunity to communicate directly with one of our IMOs. We've highlighted how proposals are considered, described the elements of a good submission, and discussed some examples. And you've done very well in your suggestions there and your votes on those. We appreciate those of you that have taken the trouble to join in on that, because it makes it much nicer for us, much more interactive. So I'm not seeing any questions. Hannah, have you received any questions?
No, no questions received.
Thank you.
I think, Jane, you've made everyone well aware of all the nuances and the approach that we take, what factors we consider in making an approved change request. What are some of the things that we like to see in a change request? What are some of the things we sort of guide you not to do? So I hope this overall gave the users or the attendees a good idea of what the thought process is.
Yes, I hope so too. Thank you. I think that's everything. We've got some links here for you just to our website. And of course, there's the links to the browser. Most of you, I should think, are quite experienced in your use of MedDRA, so you're well familiar with these. If you've got questions, you can send them to the help desk, questions about the session today, or if there are things that you want to check out, thinking before sending in change requests, you can use the help desk. Generally, we say just take the plunge and send in the change request, and you'll get your feedback directly then from our IMOs. It gives them a chance to discuss it. There's the link to the how to use change requests page that I mentioned to you before. There's our training schedules. So if you want to attend any of our other webinars, we'd love to see you. You'll be very welcome. And there's the link to our support documentation. So there's the contact page for you. Just a reminder, if any of you speak either Spanish, French, Russian or Chinese, you can join a WhatsApp group, as well as there's the English and Spanish share the group. You can scan one of these QR codes from our website to join a WhatsApp group. If we scroll down on that page, I can't scroll because it's a slide, silly me. There's a contact form underneath this. So if you've got questions, you can send them direct, or you can email us at the MSSO help. So there's also a chat that pops up that you can do instant chat when you go to the website. And that was the end of our presentation today. So anything to add, Samina? Oh, have we got any questions? Let me just have a look. Just feedback from Kirsten. Thank you very much. Lovely to hear. I think that's everything. I can go back to the browser. I just see if my polling, I can go to my activities here and see if we can find that poll that we lost.
Did we mention that this will be available within a few days on our MSSO YouTube channel, the recording of this particular webinar, as well as others?
Yes, that's right. We should be within a couple of days usually. So let me see with this one. Do you think which of the terms, this is the one? So let's have a look and see if we can see what everyone's voting was. We've got the results on that. Strange, isn't it? I don't know why it's not showing us the reviews, got the results on that one. Maybe it's me not there.
There you go.
There we go. I'm happy now for completeness. We can see that some people were like you, Samina, only adding the sensory processing sensitivity. That was the most common choice, actually, like your initial thoughts were, until you had the discussion and you realised and agreed with the rest of the team that both of them would be added. So similar thought process there. Okay, so I think that's everything. Let me last check for questions. Any final questions? Otherwise, we'll say goodbye and let everyone get on with their day. So thank you all for your attention today. Thank you, Samina, for your collaboration. Always fun to do these sessions with you. And thank you, Hannah, as well, for you behind the scenes in helping us make sure that this runs smoothly. So, hope everyone enjoys the rest of their day, wherever you are in the world. Stay safe, everyone, and we hope to see you again shortly.
Bye-bye.
Bye for now. Bye-bye.